The people register and they join accordingly, but it's there in YouTube, na? So people will that's okay.
So how are things there actually? All good now? No COVID anymore?
Yeah, no, there are patients, but they're less now.
Yeah, I think people have to live with it.
Yeah.
No other option. Otherwise, we lose a lot in life.
Yeah.
Slowly the participants have increased. Yes, okay.
Kalyan, you can start now.
Yeah, thanks. A warm welcome to everyone on behalf of ISC Kalyan. Good evening, everyone. We have had a fabulous start with our first CME by Dr. Shivkumar Singh on low flow. Attended by around 600 participants on Zoom and YouTube link. We have done 2 successful journal club presentations by our own branch members. Today is our second CME on maternal collapse. Today is also the beginning of auspicious day, the beginning of Navratri, the worship of goddess Durga, our mother, Ma. What a great way. What a great way of celebrating that we dedicate this month to learning and upgrading ourselves towards protecting our mothers, empower ourselves to do our best for our own mothers. I call upon our President, Dr. Smita Shah, to invite our valued speaker, Dr. Vennilla, and start our session today. Over to you, madam.
Yeah, thank you, Dr. Kala. Happy Navratri to all of you. As we all know that maternal collapse is rare, but a life-threatening event with wide range of etiology. And the outcome primarily for the mother and the fetus depends on prompt and effective treatment, resuscitation. So to know more about which pregnant women are at an increased risk and what are the causes of maternal collapse and its prompt treatment, today we have invited an eminent speaker, Dr. Vennilla Rajagopal. I welcome you, madam.
Thank you, ma'am.
Dr. Vennilla Rajagopal is consultant anesthesiologist from Apollo Women's Hospital, Chennai. She has done MBBS from Government Stanley Medical College and FRCA from Royal College of Anaesthetists, London. Then did PGCTCP, then Fellow of Higher Education Academy, Entry Clinical Research, Fellowship in Difficult Airway Management. Her professional summary is postgraduate anesthesia training in University of Liverpool, UK for 11 years, 3 years consultant anesthesiologist at Kowai Medical Center, then consultant anesthesiologist at Apollo Hospital. She has special interest in head and neck anesthesia, emergency surgery, obstetric anesthesia, infection control, audits and teaching. She has been an advanced life support instructor both for adult and pediatric in UK since 2008 and instructor REACT trauma course at Kilpock Medical College since 2012. She has many publications in European and British Journal of Anesthesia and International Journals of Obstetric Anesthesia and has been invited as faculty at nearly 22 conferences up till now. So now I request Dr. Vennilla to enlighten us on today's CME's topic, maternal collapse in OT. Over to Dr. Vennilla.
Thank you very much, Dr. Smita. That's indeed a very kind, elaborate introduction. It's my honor to be part of ISA Kalyan CME meeting, and I would like to thank Dr. Kala for all her enthusiasm in inviting me over for this speech today. And I thank one and all present in ISA Kalyan Executive Committee for having me here today. I hope this session is useful, and it's been a learning experience for me preparing for this, even though we deal with patients every day. And I hope this following session would be actually useful to one and all. Thank you. So may I go over to the session?
Yes, ma'am.
So are you able to?
Yes, we can hear.
Are you able to see my screen, ma'am?
No. You just do the share screen. You start.
Can you share screen?
Yeah, 1 second. I think I've gone out of the meeting. Am I still in the meeting?
Yeah, you're very much there.
Yeah.
Hello.
Yeah, I think that's done.
Yes, it's done.
Yes. Okay. Sorry about that. Okay, and I mean, as Dr. Kala rightly said, it's indeed a very special day today and the beginning of Navratri, and here we are given a very important topic, maternal collapse, and we are on to about saving mothers. It's a very passionate topic in terms of my interests, being an obstetric anesthetist, and I also feel over the last many years medicine has grown into where we are now, dealing with every intricate cancer and every possible problem that we can deal with, and yet mothers are dying from what is thought to be a physiological delivery process because of a lot of complications that happen, particularly in the current generation. So let's just look at it's going to be a quick overview of many things, and please stop me if you wish to ask anything in the way.
Yes, surely.
Most of the pictures used are from the internet, so I thank Google for that, and all the information are quoted from accredited journals, and there would be reference given at the bottom of them. So at an overview, it's going to be factors that cause maternal collapse, in-hospital management for the main causes, how do we prevent cardiac arrest? I think this is what our life is all going to be about, because once the arrest happens, the prognosis gets very poor. How do we prepare our team members? What are the human factors involved in such a very sticky, tricky situation, particularly with the maternal collapse? What is the backup support system we have? Each one of us must know who's our backup support, and how do we document, communicate, and protect ourselves from this ever-lauding medico-legal implications. So it's very important for us to do justice to the patient and to ourselves. So here we go on to define what is a maternal event. It's going to be any event where the mother has reduced consciousness level with unstable vitals. So we talk about it as an adverse event with the potential to become a sentinel event. A sentinel event meaning it could cause permanent harm or death. So even a vagal syncope, which is the cause in most of the times in pregnant women, can deteriorate and become a cardiac arrest. Timely intervention becomes absolutely necessary in such a scenario. Large number of the scenarios are preventable, and we don't want a catastrophe to happen. And this is why high-risk mothers must be identified early. So the key is to recognize them early and act promptly, and yet some may be catastrophic. So I put this picture here, which talks about maternal mortality as being the tip of the iceberg, where we have a huge lot of severe acute maternal morbidity that's happening day in and day out. And we just talk about the mortality when it comes to newspapers and journals. But what we are more worried about is preventing the severe morbidity as well. So this is two graphs, one on the left shows the statistics from America, and the one pie chart below shows causes of death in India. So the one from US shows that over the last 2 decades, the cause of maternal death from postpartum hemorrhage, preeclampsia, and anemia have all reduced. However, what they see now is a rising trend due to cardiovascular events, coronary events, cardiomyopathy, MIs. Yeah. However, in our pie chart from India, and this is data just updated in 2019, 24% is still due to obstetric hemorrhage, 20% due to infections and anemia, 15% further due to infections. So here we still have the problems that we have been dealing with. We have gotten better. The maternal mortality has reduced, but still we have a long way to go. And that has to start from every primary health center, whether in the government or private sector. And that's the way to go. So we have a long way to go in protecting our mothers in terms of maternal morbidity. So whether it's from pre-delivery, the time they enter the hospital, delivery room, at the time of giving a spinal, immediately after spinal, when you see a bradycardia, you have to act immediately, or at the time of birth, when the mother might be actually having a breach in amniotic fluid and she might throw an embolism. Or this might be how the monitor looks when you actually get called to the recovery to see your post-op LSAS an hour later in a pool of blood with a raising tachycardia and a hypotension. So events may actually go unplanned and beyond our expectations. So we need to be alert and vigilant and actually anticipate problems to prevent one. So I'd like to classify the factors leading to maternal collapse this way. Primarily from the clockwise, the anti-clockwise, the maternal factors, obstetric complications, anesthesia related, surgery related, and drugs related. So at the background, we have a pregnant mother with all her physiological features, raised, increased cardiac output, increased oxygen demand, risk of difficult airway, and a gravid uterus with itocaval compression. In this background, when we have a collapse or an event, it becomes more tricky. And that is why we need to have a prepared team and a prepared operating theater or a labor room where the scenario is happening. So when it comes to surgical factors, the first and foremost we talk about on top of the list is uncontrolled hemorrhage. In addition to that, we have the surgical handling, pulling of the omentum, exteriorization of the uterus, which can cause a vagal stimulus. Breach of the membrane between the mother and the baby can cause amniotic fluid embolism. We have the tears and the trauma, particularly in terms of atonic uterus. Does the surgeon actually reasonably do the hemostatic sutures? So those are the factors that come under surgical. From anesthetic, we have very clearly defined reasons which are quoted as the cause for about 25% of maternal death. So it is quite significant, and henceforth we have a big implication to do what we do appropriately with the right dose and vigilantly monitor. The first and foremost being high spinal. Second being inadvertent spinal following an epidural where a large dose has been given and the mother goes into irreversible cardiac arrest. Emergency GA in a difficult airway scenario. I mean, any mother could potentially have a difficult airway due to laryngeal edema or big breast, but all the more in obese mothers with PIH or diabetes, then things become more tricky. And last but not the least is the last, which is local anesthesia systemic toxicity. And we have to be very aware of what we do, and we need to have the one drug that they ask us to have, which is the intralipids. So that's that. Talking about other drugs and the effects. So drugs, we give plenty of drugs during anesthesia that can cause bradycardia, tachycardia, nausea, vomiting. Vagal tone is raised, so the exaggerated effect of the drug can happen. And anaphylaxis to drug can happen. So in the maternal reports, it's been shown in the UK that antibiotics have been accounted to 25% or topmost cause of anaphylaxis, and we'll have a look at it in a little while. With mother as a reason, we have high-risk mothers who have increasing age, obesity, cardiac, renal, you name it, and they come up with it. Autoimmune mothers, a lot of these IVF mothers have had APLA syndrome or SLE. Sepsis and COVID, this is going to be with a sepsis due to any other cause as opposed to sepsis due to COVID. I think over the last 1.5 years, we've all had many experiences with the COVID mothers, and emergency situation, it becomes very tricky, and it's important for us to have a plan of how to deal with them. Obstetric complications that put them at risk are, as I said, multiple pregnancies, IVF mothers, because of all the hormonal stimulation, and the body habitus itself changes. So they become high risk for any type of anesthesia that we give. Postpartum hemorrhage, PIH, eclampsia with a high risk of intracranial bleeds and HELP syndrome. And the pregnancy itself is not that physiological anymore. And that's why we need to have a close, vigilant monitoring. So having talked about plenty of things that could go wrong, how well are we prepared here? That's the bottom line. Is our team happy to deal with most of these scenarios? Is our team member aware of it? Have they done enough teaching for them? Have we done mock drills? Are they aware of their roles? Whom to call? How to call the blood bank? Do we have appropriate equipment? Do they know what are the things to bring into the trolley? How to bring the crash cart in? Which drugs will be there in the crash cart? Where is the ultrasound kept? Whom to call? Do you have an on-call physician or a cardiologist or an intensivist to call in the event of a crash event like a maternal collapse? So we need backup. No one surgeon or anesthetist can solve all these issues, because you will be hands-on in resuscitating the mother, and you will need adequate help to call. So it's always wise to know who your team members are and who will be called in the event of a problem. So this backup is always essential in our practice. I think that's one thing I would like to definitely ascertain at this point. So when the emergency happens, what do? When there's an emergency, we escalate the monitoring and start the management. Call for help. Call for help, as we just noted, is the first thing. We go on with our ABCDE approach. So, for example, say we've had a lady, you've just given a spinal, put her down, she starts desaturating, there's decreased respiratory effort. She's finding it difficult to talk, and she's moving her hands, but not very well. So you know that it's probably be a high spinal. And the immediate thing should be to ensure you secure the airway, breathing, and circulation. But it could go worse. She could have hypotension and arrhythmia as well, or a bradycardia. So the first drug of choice here would be atropine, if this was a high spinal. Yeah. So I'm just generally talking about a collapse situation. So we need to monitor the airway, breathing, look at the BP, heart rate, and the pulse. So the other most common thing that we see in pregnancy related arrhythmia is they're all running tachycardic as long as they are in the ward. The moment the anesthesia is given, they become brady or go at a lower rate because the sympathetic tone is taken away. So the vagal tone takes upper hand, and they do have progressive lengthening of conduction time. Multiple case reports and literature have said that this can persist, and you do not have to worry as long as it's a sinus bradycardia with adequate blood pressure and the mother is conscious and alert. However, if it is a type 2 block, or there is a loss of blood pressure or a reduced blood pressure or any other CNS signs, then you would be worried about it. So we need to be able to differentiate the benign bradycardia as opposed to the unstable bradycardia. And that is very, very important, because sometimes this bradycardia might be the first sign of cardiomyopathy, where you may need extra help to arrive. You might need somebody to come in to check the echo and check the regional wall motion. So we want to watch what type of bradycardia is actually happening. As opposed to tachycardias, again, we need to know whether they are a sinus tachycardia because of when you give the synto bolus, or whether it is an SVT or a VT, because sometimes they do go racing at 150, 160, especially immediately after the birth, and you've given synto, they're anxious, it can go fast. So we want to be talking to the mother, ensure, have a hand on the pulse, check that volume is good, mother's heart rate is good, you reassure her, and we need to continuously monitor. So when there is a drop in GCS level, then things become sticky. And when it comes to E, we look for any rashes that might suggest either DIC or anaphylaxis, any edema as anaphylactic edema that can actually blow up. You look for any blood loss, pool of blood right below or going down the drapes, and reduced organ perfusion shown by low urine output. So at this point, I would like to talk about the Muse score chart. I'm sure most of you are familiar with this, but definitely this is something that has helped the NHS in the UK and many, many other hospitals across the world to prevent maternal events, because most of the hospitals, in the small hospitals, would be led by midwives with very few doctors' support. And it is to empower the midwives to actually call for the doctors that this Muse was first used. It is applied in other setup as well, like general wards, surgical wards, so they can actually call us for help, call for the senior doctor. This essentially is a color-coded chart which has 6 parameters, where heart rate, systolic BP, diastolic BP, respiratory rate, APU scale, which is either alert, response to verbal, response to pain, or unresponsive, the urine output, and temperature, which if it is in the white zone, it is normal. Once it starts going either up or down, like the standard deviation curve we have, it's either mild, moderate, or severely abnormal. So as soon as they reach the orange zone, they know that they have to call for help. So this is where we have to get it right. As soon as they call us, we need to go observe, check the patient and get them to the right environment and prevent problem. Say, for example, this is a postpartum hemorrhage patient in the labor room. She's delivered 2 hours before. The nurse has been continuously seeing her pulse rate, and over the 1 hour, she has started to go up to 160. BP is only 70/40. She has had not passed urine still, and she's feeling very cold and not speaking very well. And the nurse calls you down to the labor room. You know that she is actually bleeding lots. You have to check the uterine tonicity, call the gynecologist, shift them to a high dependency area, get a couple of IV lines. So it helps us prevent problems as opposed to the nurse calling us when she's actually collapsed. So this is something that we have used in, we use in our hospital, and a lot of other hospitals use. We have adapted it to our charts, NABH charts, and they are very, very useful. It's an easy change to make, and definitely helps the nurses, the gynecologists, juniors to call for help. So, it makes our life easy because we're called early, so we don't have to actually pick up too many pieces. So it helps us a lot. This is another one of the tools actually recently published in a British journal, but it's actually used in developing countries like India, Africa, and South America. The WHO designed the study. So they use this manual BP cuff machine called as the traffic light shock index machine. Essentially, it's a BP machine that shows the blood pressure with the heart rate, then has a calculating machine that shows the shock index, which is heart rate by systolic. And based on the range, it shows whether it is green or yellow or red. And this enables the midwives or the nurse in the community, for example, the community healthcare centers, to pick up that this is a high-risk patient, a 34-weeker who's come in for regular checkup. She's actually picked up this and she sent you to your hospital. Then you know that which hospital this lady should go to. So you know whether she needs to go to a higher center or a smaller hospital. So it enables them to empower and refer appropriately, so thereby preventing late problems. So, and also because they know the readings are all given by the traffic lights, it actually helps them a lot. So this is something that is going to come into the government of India is trying to adapt it for the government PHCs. So that's in that's probably where we will be seeing it soon. So these are different tools essentially helping for early recognition. So that's about early recognition as a key to preventing collapse. So I'm now going to talk briefly about each one of the causes that we have enlisted from before. Does anybody want to add anything or talk anything before I proceed? Shall I carry on?
Yeah.
Yeah.
Okay, so I'll start with obstetric hemorrhage. So obstetric hemorrhage, I think often is not considered as potentially catastrophic because it's expected that physiologically a mother bleeds, she loses a little bit, she becomes anemic, then she gets some iron and she picks up. That may be the case in quite a small percentage, but many of them, particularly in the current generation, we do see that not a lot of them go into spontaneous labor, and the induced labor is a reason for a lot of hemorrhage, and atonic uterus is the main cause. So why do they become potentially catastrophic? One, we think they're not going to lose a lot, and it's often difficult to quantify the loss because we haven't actually got a measuring tape or a drape to measure them. Two, physiologically, they are okay until they lost 30 to 40% of blood volume, and within minutes they lose a liter or a liter and a half because the blood flow to the organ is so much. Uterotonics have been given, sometimes IM and sometimes IV, and it's only expected to give maximum 5 units of syntocinon in any physiological labor, but sometimes this is not useful. That is why continuous tone monitoring is important. So if you haven't given enough, then they tend to bleed because of atonicity. A delay to surgical treatment and a delay in receiving bloods, either because bloods are not available or we have just given crystalloids maintaining until the point of decompensation, and after which the blood has been requested, and then it becomes a vicious cycle. So it can become potentially catastrophic. What could be easily solved at the time, 0.1 or 0.2 comes down to 0.10, and now we are trying to grab pieces and go back to 0.1, then it becomes very difficult. So briefly to have here the 4 T's as the main cause of postpartum hemorrhage, which is 70% caused by atonicity, 20% due to trauma, 9 to 10% due to tissue damage or tissue retention, and less than 1% due to thrombin or embolism, which can be quite catastrophic. So thankfully, the atonicity is the reason for 70%, and we can deal with it. We have measures to deal with it, and if not, we can go on and do hysterectomy, so we can save the mother. So, but why is it that we are having so much of atonic uteruses? Previous LSCs, over-distended uteruses, preterm labor, mothers who've had tocolytics, prolonged labor, induced labor, previous history of PPH, age, mothers who are either in teenage or very older mothers where the hormonal imbalance is happening, and abruption. These scenarios have been well documented and well aware. So when you know that these red flags have been raised in the patient's notes, we need to be extra cautious about how much of uterotonics we are using, how long to wait before we actually go to the second step. So there has to be an active management of second stage of labor as well as the postpartum hemorrhage. So hemostasis is a mnemonic that has been suggested, and it's a very useful, easy one because here we are trying to achieve hemostasis. Yes, so H is to ask for help, and hands on uterus to start the massage. Monitor regularly so you know what's happening. E is establish airway, breathing, circulation. Get your blood tests done so you know where you are at 0.0, and get the blood products as appropriate. So once the most crucial thing in this whole management is this, because if you have a delay in getting your blood results 2 hours later, then you're failing, because if you have had a hemorrhage at 6 p.m. and your report is only going to come at 8 p.m., by then the mother's coagulation status would have totally changed. Her hemoglobin will be totally different. Her BT-CT would be different. So you need to have a system where you have immediate blood results. So most of the hospitals, I think this is the problem we have, even in whether it is a nursing home, small setup of hospital or a big one, the least we can have is bedside HemoQ, bedside INR, BT-CT, or an ABG machine. I think most hospitals have an ABG machine if they have an ER, and that would give us most of the values, lactate, electrolytes, hemoglobin, and BT-CT. And if we can get a bedside INR, that would actually help us. Or you have a liaison with a lab that actually gives you report on the phone within half an hour. So we need to try and work out where if it is an emergency and you're sending sample to a particular lab, they need to give us at least a report on the phone as soon as they can, so we can act quickly, because beyond a certain point of time, these reports mean nothing. And based on that, we are going to ask for products. So backup of blood products also, I think based on this, we need to have. Books say that all OBS units should have a backup of O negative blood, and based on the patient's blood group, if they are high risk, we should have reserved. But we all know getting blood is often difficult. So we need to work wisely here, prevent blood loss, and if at all necessary, we need to get the products ASAP. M is for massage, bimanual uterine massage. O for oxytocin, and the next step would be oxytocin. You would give 5, 10, and then 40 units running in a drip at 125 cc per hour with carboprost given, which can be repeated every 15 minutes. But usually, if you have given early prostaglandin, within second dose of 15 minutes, they act very well. But we have to remember that they can cause, bronchospasm, nausea, sometimes severe chest pain, which makes it very uncomfortable for the patient. If you're not in OT already, you have to shift to OT to get the hemorrhage sorted, or shift to higher center if you're in a smaller place. But usually we are now talking about shifting to OT. The gynecologists from their side, what can they do? They can use the tamponade balloon, like the Bakri balloon is the one that they use in our center, or a Foley's balloon is sometimes used. It's only to say gain time until they can mobilize the patient to OT, or wait for the uterine tonicity to return. This is not going to be a permanent solution. But what will be is if they can apply compression sutures appropriately, the B-Lynch, and also go on to learn how to do the systemic pelvic devascularization, both the uterines, the ovarians. So only, and then move on to do the internal iliacs or the inguinals. Unless the surgeon is skilled to do this, they need to make sure they get the senior help, because this is a very, very crucial step, and there is no point waiting or wasting time, and they need to be able to do them, which most of our doctors do. But still, if they're junior, they need to call for help ASAP. And I think we need to be part of this decision making and call for help. The hospital system should encourage calling for help in such disaster situations rather than, declining from that. Beyond this would be if she still bleeds and you have to move her to a higher center, because not all of us have the interventional radiology and embolization unit in our hospitals. Then if she still continues to bleed because by now she's either in DAC or some other vessels are leaking because she's had either a placenta problems, then we may have to shift her to a unit with embolization. But as we all know, it's usually in elective scenarios that this embolization works rather in an emergency scenario. But this is still there in the protocol. If it is necessary, deemed to be necessary, it will be done. But what is more important is one should not hesitate to do the subtotal or the total hysterectomy if necessary, because it's very, very important to save the mother's life at this point. And also, what is happening inside must be communicated to the husband and family outside, because when the mother is in such a situation, she is almost on a line, and she could go this way or the other way. And therefore, having hysterectomy also is a major life decision. So the family must be informed, and one person in the team should be nominated to communicate. So our team should be very efficient, both working inside as well as communicating with the outside. See this, how do we actually assess blood loss? I think this is always a difficult scenario. I mean, I still find that I'm always underestimating, or because there's always so much under the drape, whether it is a laparotomy or particularly in the labor room patients where you've been called to see. Or in a C-section where in a placenta previa there's shed loads of blood loss happening, we have to have certain methods or quantified so that we know more or less, at least 70% our estimate is right. So one is to make sure you know your swabs and the swab count. So dry weight will be known. So the wet weight, we will be able to judge the blood loss, what is in the suction, plus what is in the drape. These are specially designed drapes that are used to measure blood loss in labor rooms. And these can actually have, lines. So we actually know whether it's 100 ml or 200 ml. And subtracting the amount of amniotic fluid, you will know the amount of blood loss that's actually happened. So this will give us a rough estimate of the blood loss that can actually help us go on and get blood products. Because beyond a point of 1500 ml, your crystalloids and colloids are not going to help. She will need inotropes and blood products. Otherwise, she's going to be hemodiluted with a risk of coagulation problems. So how are we going to work with our targets here? So the guidelines currently from the Obstetric Anesthesia Association and from the AGB suggest that we try and keep the hemoglobin somewhere between 7 and 8, not over transfusing. The main thing here is the fibrinogen, to ensure that the coagulation is okay. Keep the fibrinogen greater than 4 grams per liter. ANR should be normal and platelets greater than 50. So if they are below that, then transfuse. So O negative if you don't get group specific, and then group specific. Fibrinogen concentrates to be given as early as we can, depending on if you have point of care testing like TEG, well and good. But if not, we would be giving fibrinogen concentrates based on the lab values. So we have them in liver units, and we can get them from local hospitals. We should probably keep something like this stocked in the hospital, because the evidence suggests that earlier the fibrinogen is given, the better, because it prevents a lot of coagulopathy, particularly in PPH patients with abruption placenta, placenta previous, and also amniotic fluid embolism, where these are the 4 cases where they have been told that earlier you give, it corrects the coagulopathy, and fibrinogen levels actually gives us a prognostic indicator as to how this lady is going to go. FFP was told to be the savior, but yes, FFP helps us, but you need to give a large volume with a risk of ARDS. So you would titrate FFP accordingly. Again, the volume of platelets given 5 to 10 ml per kg, but yes, we need platelets. They're so crucial for coagulation, and we need to give them if the platelets are less than 50. So you want to keep them about 70 so that all the parameters are met for coagulation to happen. So based on what we learned from the articles, what can we do at our workplace? So we wish to have a regular protocol and actually do audits to see how we are doing, so that we can actually make a difference. So as an organization, bedside assessments are very, very important. The nurses or the doctors, we need to have bedside assessment tools. One, we said, is the Muse chart. 2, can we have bedside hemoglobin, bedside INR checks? You need to have a liaison with the local blood bank that could actually give you blood products as and when needed. Preemptively, high-risk mothers should have a multidisciplinary team meeting, so we can actually prevent all these problems or transfer to a higher center if necessary. For example, placenta accreta, which might need embolization beforehand. When it comes to resuscitation, yes, IV fluids first to start with, but beyond 1.5 liter loss, they will need blood and blood products. The one thing that has very good evidence from the women trial is tranexamic acid. Tranexamic acid, single dose to be given earlier before 3 hours of the loss. So as soon as it's earlier it's given, the better. This, I think they have validated enough number of studies in obstetrics, like we have done in urological and orthopedic studies, that this dose is not going to cause more harm. It is going to be more useful and definitely helps with hemostasis. From the surgical side, balloon tamponade to buy time is considered very useful. And the registrar or the junior gynecologist should be skilled enough to do this until the senior help arrives if they are waiting in the labor room. The hemostatic measures must be available in the OT, or if they are in the labor room, we should be able to quickly do the procedures in the labor room if necessary. Bedside tests, as if we are able to do them, that will be the best. BT, CT, ABG, INR, and the labs, if we can get within a few minutes, at least within half an hour, we will be not too far away from what the maternal status is if we don't have a bedside tech or a Rotem machine. Because I think many units do not have them. I think 99% of us don't have it in our unit. But these basic tests would help us in a big way. The other blood products we have to optimize, and fibrinogen concentrates, I think that it's worth considering having them, or at least knowing where it is available within your city limits. So in case you need them or you preempt that some patient might need, you can actually obtain them. So that's in brief about PPH or any antepartum or postpartum hemorrhage that we can think about. And I now move on to the second most worrying complication, that collapse situation that we can think of as a severe preeclamptic mother in a hypertensive emergency. This can be a nightmare because preeclampsia is one such pathophysiology where all the systems are involved, and it is not just a single system, and therefore you name it and that organ is affected. So here we have a scenario where we have severe hypertensive mother, probably 34, 35 weeker, with worsening organ damage, end organ damage. She's got an acute weight gain for 1 to 2 days. Coming in, she could be coming in with either breathlessness, impending pulmonary edema, or a frank pulmonary edema. She could have either cardiovascular, where we're talking about this, or a CNS symptom like cerebral irritability with visual disturbances, or a clouded feeling, like she's not able to reply properly. You know that she's very clouded and she's not able to reply appropriately. There is probably cerebral edema going on. And third, but not the least, is, or the worst would be the worsening coagulation with DIC. She could present as an abruption, or she could present with PV bleed. This would be one of the nightmare of a scenario to deal with, where you have a hypertensive mother with a bleeding scenario, and you actually have to deal with them straight away. Renal shutdown, they begin to show reducing urine output, or they might actually just come with showing fetal CTG changes or Doppler flow changes and nothing else. Not necessarily having proteinuria all the time. So when one of these organ damages or fetal changes are seen, you know that there is problem, and this lady needs to be taken into HDU area or an obstetric ICU area before things go wrong. You have to optimize the blood pressure and then consider delivering as and when appropriate. This is how the obstetrician takes it call, but we have to be equally involved from the beginning so that we know who we are dealing with. At this point, they have to have regular monitoring. So this manual cuff, although it helps to take for obese patients, we need to have an automated system where the hands free for the nurses, and a regular continuous monitoring is done, and they should be put on Muse chart, and you start antihypertensives. Call for help. A senior should be involved definitely when these sort of cases are done, and we should always have a backup plan of how we are going to deal with such mothers. So first is medical management. You try to get the blood pressure below 160/110 with labetalol, first line, nifedipine. Monitor the response and see the end organ response. How is the cardiac doing? How is the ECG? How is the echo? What is the neurological status? Is her irritability reducing? Is she talking better? What's she on the APO scale? What is the urine output doing? Okay, and the blood parameters. We immediately send the bloods off for liver functions, renal functions, coagulation, and electrolytes. And this will give us an idea of what's happening with all the organs. If the BP still persists, then we start with IV max sulfate. So max sulfate is a one and all a beautiful drug that it's called as the anesthetist friend when it comes to obstetrics. Not only in obstetrics, in bronchospasm, in ICU generally, and in cardiac OTs. So IV max sulfate is given in severe hypertensives and at the onset of particularly any end organ damage symptoms. So the dose is quite familiar for most all of us. It's a 4-gram bolus IV followed by 1 gram per hour infusion. And any bolus dose might have to be repeated if there is a seizure. What is the fluids that are going to be given? You restrict the fluid to 70 or 80 ml per hour based on the weight. Aim for urine output greater than 0.5 ml per hour. There is no preloading or co-loading at any one point because we know that it's it's all full and we are going to be on the brim of pulmonary edema or a cardiomyopathy in such severe hypertensive patients, it's better to run them dry. Avoid volume expansion. Okay, a quick ABG with electrolytes will give us an idea about the vasospasm and the end organ values. If the lactate is high, you know that something else is also going wrong, and it's very, very important to know that. So when this preeclamptic lady has a generalized clonic-tonic seizure, then it's called the eclampsia. And as I said before, if she is going on to have a seizure, we will repeat the max self dose. But we are not, the current guidelines actually advise not to give benzodiazepines. Also, most of us tend to give 1 or 2 milligrams of either lorazepam or midazolam. But why it is suggested is that it can obtund the neurological examination. And that is why it is suggested that we don't use benzodiazepines. However, you think that you're going to give her a GA anyway, then it might be okay. But the guidelines suggest not to give benzodiazepines at this point. So we go on to continuously monitor her vitals, including the mental status for bleeding, coagulation status, and liver enzymes. If she's in status epilepticus with recurrent seizures, and then we know that the mother and the baby are getting compromised, now is the time to take action. So we call for the team. We do obstetrician, anesthetist, and the NICU, all of which you have enough hands to help. They know what they're going to deal with because the baby and the mother could be compromised. We get a high-risk consent form from the family and we move them ASAP to the OT to deliver the baby. So usually if it is a single episode of seizure, we do not immediately deliver the baby. We allow for the mother's vitals to settle down. We make sure coagulation is okay. And then we take them into theta because it also helps us to decide the type of anesthesia. However, if it is a recurrent seizure and the mother's GCS is low, then we don't have any other choice but to give a general anesthesia. And we have to consider that this is going to be a cardio-stable, neuro-stable type of anesthesia, induction and maintenance that's got to be given. With no chances of hyper or hypotensive episodes should be allowed. Any yo-yo in the BP means it's going to compromise the mother and the baby. So this is what we're talking about. With recurrent seizures, we go on to stabilize airway, breathing, circulation with the mind that there could be a compromise in the mother and the baby. You do deliver the baby by cesarean under general anesthesia. Continue the max self. Please do not stop the max self when you shift to OT. Continue the IV antihypertensives, whatever we are giving, either IV labetalol or IV GTN that might need to be added. Check blood gas. She will certainly need an arterial line. Correct the electrolytes so we do not have problem, particularly with somebody who's had magnesium. We will have to be cautious with the dose of neuromuscular agent we give. Repeat blood investigations. An echo and ECG would be most ideal before we induce if time permits. But if not, on table or off table before extubation would be ideal in these scenarios. So what we need to remember, as I just said, a yo-yo in blood pressure can cause an intracranial bleed, acute pulmonary edema, hypertensive cardiomyopathy, and most of these can even cause a sentinel event. So this is what we are worried about. We don't want a sentinel event happening. We don't want this lower part of the iceberg enlarging where you have a paralyzed mother or a vegetative state mother or a lady with a chronic, lady with an MI who goes to ICU and then dies. So we want to prevent all of that happening. So we ensure that the blood pressure is controlled during anesthesia, intubation, and if you're not planning to extubate, then shift them to ICU and slowly extubate under the care of cardiologists. So that's very, very important decision to make. And henceforth, a team has to discuss and decide in the best interest of the patient. So one more scenario that can be quite tricky is the HELP syndrome. I think this comes as a part of our severe preeclampsia that moves on to become HELP, where you have hemolysis, elevated liver enzymes, and low platelets. So HELP syndrome is always from the days of UG undergraduate, we've been taught that HELP is fatal. So deliver the baby. Yes, HELP definitely can be fatal and has a high risk for the mother and the baby, but that does not mean that you need to deliver the baby that second. What you need to do, it does not equate to prompt LSAs and baby delivery. What it means is Delivery is the cure, but not immediately unless the pregnancy is greater than 34 weeks. There is some fetal compromise or IUD, the baby is actually compromised already, or there is a compromise to the mother's life. If like there is an abruption or a hepatic rupture, something like that, then you may have to deliver the baby. So until then, if it is an class 1, class 2 or class 3, so depending on which grade of HELLP syndrome it is, you need to manage conservatively and then decide. You need to buy time. So maybe 24 to 48 hours. It needs to be a combined decision between the obstetrician, anesthetist, intensivist. Ideally, such patients should be in a high referrals area. Steroids for fetal maturity. Stabilize the mother with antihypertensives, magnesium for fetal neural protection and for the mother. Fluids with caution, coagulation and platelets to be continuously checked. Check for any internal bleeds, make sure CT head, the liver is okay, any pulmonary edema, ultrasound, a quick, if we are able to do an ultrasound, that would be the most important skill that we can have bedside to check pleural effusion, any ascites, any liver bleeds, then that would be very, very useful. All of these would help us decide whether the lady is safe for regional or should we go on to GA. And that helps us make a decision. So this is a slide that I have taken from the Anesthesiology 2017, talking about when would we actually have a contraindication to regional anesthesia. So they have clearly defined that when the mother is decreased level of consciousness, as I said, in an eclamptic mother who is with low GCS, thrombocytopenia or coagulopathy, as in totally deranged clotting that you cannot give products and reverse because she could actually continue to be coagulopathic, or thrombocytopenia as in less than 50. Severe hemorrhage, both internal or external, like an abruption, systolic heart failure or valvular stenosis. In these, if these situations are present, you please go on to do general anesthesia, which is actually a small percentage of case, but it's very, very important that you know when to give general anesthesia and how to plan for this high-risk general anesthesia. Plan for the difficult airway, particularly if it is a HELLP syndrome and they have coagulopathy, they can bleed from everywhere. The airway could be difficult. You prepare for a difficult airway or be prepared for a difficult airway always. Optant blood pressure response on intubation, modified RSI, careful titration of anesthesia. It's very, very important. In others, we can go on to have general anesthesia. Of course, spinal, single shot, atraumatic. Vasopressors might have to be used instead of volume overloading. Very slow oxytocin to be administered and avoid methogen. That's something we have to be very, very careful about. And post-op, these patients have to be in a critical care unit, definitely. So that was about the preeclampsia, eclampsia, and HELLP syndrome patients, and how do we actually prevent them from going on to have a collapse, or if they did collapse, what sort of situation will we go on to? The third most important reason that has been documented is the cardiac causes, and I think post-COVID we have seen plenty of cardiac causes due to coronary events on the rise, COVID mothers particularly, and this has been the scenario in US even before. On the right side here, I talk about women, older age group, IVF, PIH, obese, COVID, the APLA mothers, SLE mothers, rheumatic heart disease, congenital heart disease, or new onset coronary event could actually happen due to the stress of labor or C-section. So it is mandatory that we get an echo in all the high-risk mothers during pregnancy, or at least if they are coming in with symptoms that might suggest cardio or respiratory compromise, then we need to have an echo done prior to theater. At least a screening echo, which would help us identify if there is any regional wall motion abnormality, any valvular thing. For example, a very benign mitral valve prolapse could have changed into regurgitation. What could have been, a lady could have been compensating very well with an undiagnosed congenital heart disease, first time presenting. I had a lady with coarctation of aorta who presented for the first time in the 3rd trimester. She was never diagnosed with congenital heart disease before. Because of the breathlessness and extreme fatigue, we went on to do the echo, and then we diagnosed that, and then she did complete her pregnancy. We did an elective section under epidural and she went home successfully. But the point is to diagnose at that point before she deteriorates. So we need to sometimes the breathlessness that a pregnant mother complains is often not taken. The pedal edema is not considered. The tiredness is not given due importance, but we should actually get a physician opinion, and there's no harm getting an echo. In fact, the government had suggested that maternal echo is mandatory in a lot of these high risk mothers, and it's going to be in vogue from now on. So they can go on to progressive deterioration. And the most common thing that leads on to cardiac arrest is arrhythmias. And I think this is what we talked about, bradyarrhythmias or tachyarrhythmias. The key is to recognize early, and we have to follow the ALS protocol. If it is hypo or hypertension, we follow the protocol as per the what we would do. For hypotension, we would go on to have inotropes ready. The best choice would be to have, although we would have used phenylephrine as the first drug of choice, if it is a continuous hypotension, it would be noradrenaline as the drug of choice for hypotension in pregnancy. Coronary event, if you do see ST elevation, patient has chest pain, and it could be triggered by the dose of prostaglandin, or it could be triggered by PPH and prostaglandins given. Then you start ST elevations seeing, then you want to correct what, if it is a volume loss, have a 12-lead ECG, give adequate analgesia, make sure she's not in stress that could make it worse. We will need a cardiology opinion at that point. Pulmonary edema is probably thought of as the most easiest complication to deal with if the kidneys are working and if the capillary leak syndrome is not as bad, and it responds to the first dose of 40 milligrams Lasix, which we do in a florid pulmonary edema. However, during that point, we have to remember that we actually do a good controlled ventilation, low tidal volume, not too much pressure, maintain the PEEP, so we don't cause more damage to the mother's lungs at that point. So the principles are the same that we would apply to any non-pregnant lady who goes through any of these problems that we have learned in anesthesia as a career. We have to follow the ALS protocols, but the point is to recognize that it can happen in the mothers. MI can happen, a pulmonary edema can happen, and to actually spot them and move on to use the regular drugs as we normally use. If it happens prior to the baby, we would like to deliver the baby ASAP, and so that it's not only for the baby's sake, but it's also for the mother's sake, because the placenta and the baby actually takes a huge load of, metabolic demand on the mother. So delivering the baby and securing the mother actually gives her a chance to move forward. So these are the standard protocols, which I'm sure you're able to see. These are the latest guidelines from 2021 in case of arrhythmias. I'm not going to dwell upon them, except that I'm just going to say this blue, dark blue, life-threatening features. If the mother is in shock, if she's got a syncopal attack, if she's having an MI, and if she's in severe failure, like if you're having an arrhythmia with this, please go on to have synchronized shock. Do not hesitate to give a shock, because we're not going to be just treating with amiodarone and drugs. So do not hesitate to give shocks. I think with regards to bradycardia, we took, again, if there is a life-threatening bradycardia, please go on to give atropine. But if atropine is not responding, she might well need adrenaline. Isoprelin is also a drug of choice. If it is not available, adrenaline has to be titrated to ensure that the heart rate is going on and you have adequate cardiac output. Pacing and all the other options would be next, but what we are talking about is the immediate action, and I think atropine is your drug of choice, and it should always be an ampule drawn up and kept on top of the OT theater, OT machine, and it's very, very, very important drug. And I never start a case without atropine and adrenaline drawn up and have their labels on, so I know where to go, where to reach my hands to without asking anyone. So going on to the next one, I think arrhythmias is one important one. The reason why arrhythmias are considered to be more common in pregnancy, particularly under anesthesia, spinal or epidural, is that the demand on the heart is more. They also have the myocardial irritability, which is increased, which is actually a physiological change due to the hormones that's actually happening. So electrolytes, once you check them, and if at all they are low or high, you need to correct them. So that would actually help in most of these patients. So I move on to this Catastrophe. I think this is what Kala wanted to mainly, I think, meant by catastrophe, because I think amniotic fluid embolism is one catastrophe that I don't want to have any of my patients to have, or I don't have to deal with in theater, because I think it is just too sudden. It presents itself too sudden, and there is too many things going wrong, because it is not just a phenomenon of amniotic fluid moving back into maternal circulation and causing a PE. It is not just that. It is triggering what they call an anaphylactoid phenomenon that raises the complement system. It releases your histamine, bradykinin, and all of these nasty inflammatory soup mediators that go on to cause severe hypotension, myocardial depression, fluid overload, capillary leak syndrome, and DIC. So they could actually present with fetal compromise as the first symptom, or seizure, or shortness of breath, or hypotension, or cardiac arrest. It could be the first scenario. It could happen either during delivery or immediately after delivery, usually, sometime about 20 to 30 minutes after. Most commonly, what I have been told, or certainly I have witnessed one, is you get called from the recovery, post cesarean, the mother's left in the recovery, and then suddenly she just crashes, where this is all induced labor. These kind of patients actually have a high risk, because the hormonal, the trigger is different, and therefore the breach is also different, and they can actually have a amniotic fluid embolism. A lot of causative agents are based on many postmortem studies. Until you have a patient in whom you have a definitive diagnosis, you don't actually have a postmortem study, you don't have a definitive diagnosis. But if a particular scenario happens in a sudden way, then you know that it's probably most likely amniotic fluid embolism. And if it gradually is a hypotension, then progressing to cardiac arrest, you might at least have time to help. Otherwise, it can be very dramatic. So the management is supportive, can lead to PPH. You need to deliver the baby. If it is just happening during the time of delivery, the baby must be taken out immediately, so you can help the mother and at least save the baby. Transfusion protocol should be initiated, because if DIC is onset, this lady can be pretty dramatic going down to the pathway. If you check, if you think of amniotic fluid embolism in your initial blood list, you should also think of C3 and C4. This is what the guidelines, British Journal of Obs and Gynae guidelines suggest in these set of patients. And you can check your fibrinogen and platelet levels. It will give you an idea. In these embolism patients, because of these anaphylactoid phenomenon, it is thought that the C3, C4 levels are really raised and the fibrinogen levels are very low. And that gives you an indication again towards this as a diagnosis. ABG and lactate should be done at frequent intervals. Fortunately, if you have a lady who starts responding to your initial supportive management, then you know that you're on the right pathway, and she will well need ICU or CCU postoperatively. So this can be quite dramatic, the way they present, and amniotic fluid embolism should always be at the back of your mind when you see a lady suddenly collapsing. So yes, coming back to our anesthetic issues per se, which I quoted before, that it is a reason for 25% of the maternal deaths in one of the American journals. It is, and also in the UK CMAC report, it was reported. So primarily due to high spinal drug reactions, which both can be immediately dealt with. If immediately dealt with, you can actually save the mother immediately, save more trouble happening, and you can prevent cardiac arrest. But if severe anaphylaxis, and again, you need to make sure in anaphylaxis, you have the risk of airway being compromised. And that is why immediate prompt action matters. There is no time for fiber optic intubation, or sometimes supraglottic airway will not sit in anaphylaxis. It is not the right choice either. So securing a good, even if it is a small size ET tube, becomes primarily important, either with your choice of McCoy blade, or if it's a video laryngoscope that you regularly use, should be used. So you're not using an instrument for the first time on this particular patient with a compromised airway. Adrenaline is a drug of choice, and we move on, so that acts very quickly. Hydrocortisone and chlorpheniramine. These are the three things. You secure the airway, get somebody to give the drugs, and you should be on the recovery line if she starts responding. So its immediate action is required, ABCD approach, and you follow the ALS algorithm. And last is the local anesthetic systemic toxicity. I'll talk about it in detail, and the difficult airway. So when we start any case, it's very important that we have our emergency trolleys checked and ready always, your oxygen supply, your emergency trolley, your difficult airway trolley. And it is also mandatory that every so often we have our teams, your technician, your nurses, your labor room nurses, and your midwives, as well as a obstetric team, to know that if things go wrong, where they will get things for us, and also whom to call for help. So these things should be rehearsed, and your trolleys should be always available. So we need to get our trolley ready with whatever support system you have. So if you want your task scope, if you want your glide scope, and you have kept it in a table, that should be brought to you in the time of emergency. So that information must be communicated beforehand, rather than at the time of, you know, panic and when the actual things are going down the fire. So this is about anaphylaxis. As I said, antibiotics are top on the list, followed by muscle relaxants and even fluohexidine dye. 96% of the times things go well because the anesthetist has acted swiftly. Low blood pressure was the first thing that happened, and 15% of the time patient ended up having cardiac arrest only because when the BP was low, and the CPR was often very delayed because they were probably waiting for things to improve and the CPR was not initiated. But it's very, very important to keep up a hand on the pulse, because sometimes you do have a rhythm, but there could be pulses, electrical activity, and that is very, very dangerous because it scenario to actually reverse. So our friends in this scenario are adrenaline. As an anesthetist, I think we all will be happy to give an IV dose, 1 milligram, slowly titrated if in a cardiac arrest situation. If not, it would be 0.5 milligram first and then another 0.5 milligram if needed. Any other doctor would be probably giving it IM. You get hydrocortisone and hydrochlorpheniramine, secure the airway, breathing and circulation. You may need an arterial line or at least a blood gas to quickly check what's happening. Good going IV lines are paramount importance. There's no harm. There's no point trying to get a central line or to get your inotropes or all of that, because a good 1, 2 on either antecubital fossa or your external jugular veins are the best. I promptly rely upon my external jugular veins all the time because they've saved lives all the time. Because where there is no time to get your ultrasound or your central kit open, a good 18 gauge or a 16 gauge into external jugular vein will save all the trouble, and you can give inotropes comfortably through them with a Q site or a 3-way connector. There is no problem with that. Next drug I'd like to talk about here is the Maxsulf toxicity. I think we use it so much so now that Maxsulf is a part of labor rooms. We get 90% of our cases are high risk, and of which I think more than half are preeclampsia, and they end up having Maxsulf prior to shifting to OT. We try to remember the Maxsulf toxicity, how to pick up toxicity, because nothing is without problem. Anything we do has a side effect. So is anesthesia, and so are the drugs. So Maxsulf toxicity, we have a mnemonic called burp. So some of you are familiar because it's usually used by the nurses actually. BP is decreased, urine output is decreased, respiratory rate is going down because they're just slowly sleeping away because there is no electrical activity happening in any of the muscles, and the patellar reflex is absent. So if you pick up this, then you have to indicate to your senior the Maxsulf dose has to be reduced or stopped, send serum levels off, and give an antidote because they can slowly go into arrhythmias or bradyarrhythmias. So you may want to titrate. The antidote here is calcium, either 10 ml 10% calcium gluconate or calcium chloride. Very carefully under monitored environment should be given. We could probably do it rather than the nurses giving. So last but not the least is the last, and I think we use so much local anesthesia these days with all the nerve blocks, the volumes used, and there is so much safety margin that's improved with the type of drugs we have, moving away from lignocaine to bupivacaine to levobupivacaine to ropivacaine, and yet we should remember that it can cause toxicity if it goes into the wrong layer, or if it is in an excess volume for that particular patient, or if it gets absorbed. Okay, the bioavailability increases for whatever reason, then the systemic toxicity can happen. So what are the doses? I think for lignocaine greater than 5 milligrams per kilo, bupivacaine and ropivacaine 3 milligrams per kilo. And we need to know how much dose has been given and during a particular period of time. So if the recognition is here, they can either have neurological or cardiological, either it is twitches, seizure, sudden loss of consciousness, or they can start off with hypotension, arrhythmias, and actually loose airway. So here we move on to treat it immediately, stop the injection, call for help, and get the rescue kit. So this is very important that all of us actually stock intralipids. It is mandatory. There is no other choice. Even if you don't use it for the entire period of time and you have to throw it, that is fine. But we need to stock it. I think we need to convince the hospital management for stocking this because a lot of case reports, even in the Indian Journal, as well as in many of our other journals, that as soon as they have recognized and given intralipids, the mothers or patients have been reversed back and they haven't had any further events. So it's very, very important. The dose for a 70 kilo patient would be 100 ml. You're less than 70, you titrate according to the weight. The dose can be repeated and you reassess. So essentially it goes in clubs of the drug, and by competitive inhibition, it takes away, and therefore it takes it away from the receptors and prevents you from blocking the neuromuscular agents. So rebolus may be needed. This is very important. All the regional anesthesia societies all over the world have suggested this. If you do have a problem and your patient has this and we don't stock it, then it will be a serious issue, because I think it's mandatory. We used to say that propofol is also a lipid and we could use it, but I think we have gone far away from that in the last 15 years since intralipids were introduced, and I think we should stock it, and very much available in India, and we should stock it. The one thing about last is because it's all about irritability of the cardiac membrane and the neuronal membrane, there are few differences in the cardiac arrest scenario. Okay, so one is you reduce the adrenaline dose that may be required because the irritability will be high. You may give half a dose. Avoid vasopressin, calcium blockers, beta blockers, and any other local anesthetic, lidocaine as an anti-arrhythmic drug. So it is very important to remember this. Benzodiazepines are the drug of choice. Don't give too much propofol. As I said, these act as too much lipids. It can actually alter the metabolism of the other drugs that we are giving. So we don't want to be confusing the pharmacokinetics and pharmacodynamics of the drugs given. So the ASRA guidelines say who are at high risk, small BMI mothers, with whom you give large doses, known cardiac arrhythmias and electrolyte abnormality patients are at higher risk. So be careful when you titrate the dose for them. The ECG could be either bradycardia, white QRS, or a VPVF or asystole. ACLS, what is different? This is what I said. Amiodarone will be a drug of choice. Don't use nodal blockers. Reduce the dose of adrenaline. Avoid vasopressors too much. Intralipids is your choice, and the resuscitation may have to go on for longer until the drug is eliminated. So you need to continue this. This is like the hypothermia mother situation. You need to continue, in hypothermia, like until they get warm. Similarly, until maybe half an hour, 45 minutes, up to even an hour, we need to continue until the effect of the local anesthesia goes. So here we are coming to the most dreaded one in obstetrics. I think it has always been imprinted into the brains of the anesthetists that obstetrics is difficult airway, and it could be a failed airway, therefore go for regional. We have, whether we give regional, spinal, or local, we need to know that we should always be prepared for airway management in any patient that we take them to theatre, and henceforth our theatre and ourselves, we should be equipped for that. So I'm sure this is how most of us are practicing already. The DAS guidelines clearly give beautiful guidelines, and the recent ones are so elaborate that I don't actually have to go into it. But what I would like to just emphasize is equip yourself, train yourself, because maternal airway can be tricky due to the physiological changes and the time in which you're expected to put the tube in, because there is no point of reversing back or waking the mother up, or there is no time for actually doing a cricothyroidotomy or doing it under any other way. So it's also a pressure on the time and pressure on the person themselves, which makes it more difficult. So you make sure that you equip yourself, train yourself, so you're comfortable doing what you're doing. Okay, so nasal para-oxygenation, ensure that you're adequately pre-oxygenated and continue the para-oxygenation during the time of intubation. Ramp position, I think this we need to ensure whether you have an actual ramp or whether you actually have sheets folded in and kept for that particular patient with a head ring. You need to decide that and have it, and your assistant should be able to give it to you. 2 anesthetists if you're going to go in for a GA, or particularly if you think that it's going to be a difficult airway. A backup airway plan should be there. Cricothyroidotomy kit should be there at the bottom of your airway trolley. Whether it is a small cricothyroidotomy kit or a tracheostomy kit that anybody else in the hospital can do, it should be a crico kit should be available for emergency airway. I think there is no two ways about that. So this is the algorithm. This is just the master algorithm, which talks about the safe GA, failed intubation, can't intubate, can't ventilate. So this is quite elaborate, and I think the algorithm is self-explanatory. And what it talks about is trying to be safe. If you have, make sure you adequately planned. Give 2 attempts at mask ventilation. Don't worry about cricothyroid at this point. Use SGD if it fits and you can ventilate. Make sure you've adequately paralyzed before you actually go on to do the cricothyroidotomy, because it is not laryngospasm that is causing the problem. So these are the important salient features from this algorithm, but it's well worth going through it and having it in your mind all the time. So unfortunately, if it, despite all the efforts taken to manage our maternal collapse situation, if it moves on to have a cardiac arrest, and there is a code blue situation and there is panic and people running, either it is an already sick lady going on to have a cardiac arrest, or a sudden cardiac arrest is what we hate, because we haven't anticipated and we have no clue who this lady is, then it becomes tricky. But either way, we follow the same protocol. It's ALS algorithm. There is nothing, new about this. We have to start CPR, cardiac compressions first, hand mid-sternum slightly above so that you don't jump on the baby. It has to be mid-sternum, slightly above the xiphosternum. Continuous cardiac compressions 30:200 per minute. The most important thing is to have the uterus manually displaced so that we can actually eliminate the iotocaval compression. This has to be manually done, or that actually helps to take away the pressure. This is the core important point that is different in ALS for pregnant mothers. Secure the airway. As I mentioned before, it could be tricky airway. You'll need small tubes, 100% oxygenation with cardiac compressions. Even if you get 9 to 10 millimeters mercury of carbon dioxide in your EtCO2 monitor, that's good enough. That is suggestive of a good CPR. So it's important to see some carbon dioxide coming out of your, which is seeing that there is some circulation going on. Avoid hyperventilation. Cricoid pressure is controversial, and it's, I think more and more people are trying to see that it actually intervenes if you're trying to use that at the time of intubation when somebody is doing chest compression. So if it helps, otherwise don't be bugged about it. You can drain with the, if you drain the stomach soon after intubating. So this was an article, actually this is quite long ago, 2012, published from an American article, which says if the mother's presenting rhythm is PEA, then chance of survival is very poor. However, most of the other times it's about 50 to 60%. So if it's a shockable, please get shock as early. If it's asystole, give adrenaline and continue cardiac compressions and follow the ALS protocol. The chances are 50 to 60% you will get the mother back. Otherwise, it's quite poor survival. So it's very, very important for us to recognize what and follow the shockable or non-shockable rhythm. Uterine displacement is considered very, very important, and then to take away, improve the venous return and help the mother. Good IV lines, get the drugs in. So this is the ALS protocol that we're going to follow. Don't forget the H's and T's. Ensure continuous oxygenation, chest compression, adrenaline every 3 to 5 minutes, and amiodarone every 3 shocks. So this is important. At the same time, if you're able to do a quick ultrasound to see, or a quick, to see if there is a bleed or anything, that would be useful. But I think you have to continue this until the point of time where either she returns to circulation or the team decides that we haven't identified a reversible cause. So this Bu-CHOPS is one mnemonic that we use for maternal cardiac arrest, bleed, embolism, anesthetic reasons, uterine atony, cardiac causes, hypertension. Others will have the 4 H's and T's, placental problems, and sepsis. So don't forget sepsis in all of this. And infective cases are still 15% of our maternal death. And if we give the right fluid bolus, it could be a septic shock, then they could be quite easily reversible, and then we could shift them to ICU and treat the sepsis. So it's very important to consider this depending upon the history or a brief history that you've had from the patient. So I'm just going to quote on what few differences that the OAA had suggested, or rather people might have doubts during CPR in a pregnancy. If you've never, fortunately, if you've never had a situation of maternal cardiac arrest, these doubts might come if you're facing the mother having a cardiac arrest for the first time. First and foremost, ALS is the same. The only thing is you give the uterine displacement or deliver the baby ASAP. The chest compressions should be given mid-sternum. Otherwise, you just continue the same cardiac compression. Secure airway breathing, circulation. The rhythm check should be done and you follow the same protocol. AED can be used. It's very, very useful. And if you happen to be in a labor room or you have an AED there, it's very, very useful. If it doesn't work for the first 3 shocks, then you can change the paddles. But AED pads are very useful. Use defibrillator as indicated. Fetal monitor, not necessary, because as long as the mother is alive only, the baby is going to be doing good. So we're not going to be wasting time about fetal monitor. If the cardiac arrest continues beyond the first minute or the second minute, perimortem cesarean delivery must be thought about immediately, such a way that you think about it immediately, you start prepping in the 3rd minute and you deliver by the 4th minute. If it is happening in the labor room on full dilatation, then you need to do instrumental delivery. So this is how quick the decision making must be happening. As far as the drugs are concerned, it's the same, adrenaline and amiodarone as regular. Uterotonics, if you're going to give after return of spontaneous circulation, give a slow infusion. So the key to remember here is uterine displacement. Don't fuss about fetal monitoring. Continue with the defib and the drugs as regular protocol and deliver the baby within 4 minutes. So do not keep moving the patient and losing time if you're in labor room. There should always be a plan where if the mother collapses in the labor room, delivery should be done there, or a perimortem C-section should be done there by a good experienced surgeon who is able to do that either through vertical or transverse incision. We should have a backup airway breathing system that we can actually use in the labor room, and a surgical pack must be ready, because the longer we wait, then the chances of survival for both the mother and the baby declines exponentially. So this is a checklist that a labor room should have. And I think this is something that all major hospitals may have. And even I hope most of the units do have. But having a cesarean kit for the surgeon to actually do should also be there. So we're not actually wasting time. Don't the Obstetric Anesthesia Association actually clearly says, don't get bothered about electrical equipment, getting diathermy, etc., because there is no blood flowing at that point. So ensure that your pack has skin prep, gloves, drape, do it in a sterile way. A single drape, that's it. Scalpel, clamps, artery forceps, joints retractor, your scissors, needle holders, and some suture material. Yes, so we move on, deliver, and once the mother's return circulation, then you move to OT and close up the wound. From our side, from the anesthetic side, we need to ensure we have an oxygen source. If not a cylinder, there should be a water circuit or a Boyle's machine. If you're able to offer, have one just for the labor room, that would be worthwhile. But until then, you can use the airway and the water, cylinder and the water circuit. ETCO2 monitor should be there in that emergency trolley that you have, because a mobile one that you can connect to the monitor should be there. So as soon as you've tubed, you know that it's confirmatory ETCO2 and you can actually move on, and that would help you go on and do other things. Laryngoscopes, appropriate ones for the maternity unit, short handle, smaller ET tubes, LMAs, appropriate number of IV cannulas. Intraosseous needles are, not really thought of much in adults, particularly in obstetrics. I think we would be thinking very hard about using an intraosseous needle, but there are a lot of case reports, and the Resuscitation Council suggests that intraosseous needle, particularly into the tibia, would help infuse large volumes and help in hemorrhage situation. So, but it needs to be given in a pressurized manner, but that's something to think about. It may be something that might be useful, but definitely your usual IV lines, drugs, pressurized chambers, warmer, difficult airway cart and crash cart must be available for the labor room unit. So these are the recommendations for airway equipment and the routine airway equipment. So I think you would be able to get this from the AGBA guidelines and the OAA guidelines, but I've just, these are the regular ones. What is more important is the nasal cannula, oxygen tubing, and the equipment for ramping and ETCO2. These are the 3 points which are very, very important that a lot of places might actually miss. Post-resuscitation, the anesthetist must ensure that we are continuing the care, maintaining vitals, checking the bloods, lactate, ABG, coagulation, and CO2 monitor, shift them to an appropriate place. Surgeon would close up the wound, and if at all necessary, a balloon tamponade, because now you've given circulation, there might be atony, there might be more hemorrhage. So the surgeon might have to sort that out or do a hysterectomy. So we are in a tricky situation, but it's very important to hold hands. And that's why if you had enough hands to help, it would be very helpful. So just coming to the end of my talk, I think it's been quite a lot. I hope it's not been dragging. I hope it was interesting. This is last but not the least, I would like to talk about the teamwork. So if we have a system of how to train our people, so it would be very useful for us on the days, on rainy days like this. So regular drills, education, the language familiarity. For example, this is an emergency, get me the crash cart. This is a drug, give a flush or give a bolus dose. The person with you should be able to understand what you're saying. High-risk consent must be obtained. Do not forget in all your goodwill to help the patient that you haven't actually got the high-risk consent form, because despite what we do, the family who pays for it and who's actually the family member of the affected needs to know what the mother is going through. So it's very important to communicate with them. Role play with the team helps. Strong liaison between the doctors and staff and the lab and the super specialists. So if you're going to call for a cardiologist or an intensivist, it's very important that time to time we tell them what problems we have so they can actually support us in the appropriate manner. On the day, declare it's an emergency, open the mouth, communicate, call for help, assign roles, tell people I will be doing this, you do this, and call for help so that person can come and do this. It's very important to maintain situation awareness, act by protocol, because it is for these times of emergencies where our thought process can get affected that these protocols are made for. It is to help us. So if we stick to the protocol, I mean, according to the what suits your place and nursing home, you can always go back to ABCD if something fails. But so you can start from airway, breathing, circulation, and try and work out your pathway. Documentation by timeline is very important. One person for communication and one person for documentation is very, very important, because these timelines are very, very helpful. And post-event, it's important that the team sits and talks about what happened. You know, what could be done better, why it happened, what was done, and what could be done better, or, you know, what went well and what didn't go well. That's very, very important not to blame, because if there is a blame culture, we will never be able to progress. See, after all, we are humans and human errors can happen, but with the system of help and team work, we would hopefully reduce the number of errors and actually work constructively for the future. So the next time that member of will be able to function effectively rather than with a fear or guilt. So that's very, very important. I think that's one thing that I learned from my training days, and I like to continue with the way I train with my team and colleagues, because that's what I expect from them. So that's very, very important. So in summary, I would just like to say that maternal events are often with severe morbidity and mortality. Early risk identification and stratification actually saves big time. It helps you a lot of ways. Muse scoring of inpatients are proven to prevent med calls. Med calls meaning medical emergency calls. So you actually prevent all of these disasters happening, then we would be in a sailing ship beautifully. Active management of known complications with regular drills and training. You build a team with appropriate personnel and equipment. So they know what the plan A and plan B is. So you don't have to, worry about that. Thank you very much for the opportunity. I close with this.
Thank you, madam. It was a, hello.
Yes, ma'am.
It was a very lucid presentation. Most of the doubts are cleared. Today we have Dr. Nandini Dave has joined us. I will request Dr. Nandini Dave to ask some few questions.
Sure, ma'am.
Dr. Nandini Dave?
Yeah.
Yeah. Yes,
So,
yes.
hi. So I had a question
Vennilla, you
regarding,
can stop sharing.
Yeah.
So thank you, Dr. Vennilla, for that lovely presentation. So I'm a
Thank you.
pediatric anesthetist, but our hospitals have also started doing obstetrics. And so I've come back full circle and I'm also doing obstetric anesthesia. So my questions may be slightly maybe simple or silly, but I had a doubt about Pitocin dose, which you use on a regular basis for sections, because from what I've been reading extensively is that we are going very low on the Pitocin dose. But our obstetricians keep asking us to give, the standard doses. So what do you recommend?
Yeah, see, as you rightly said, I think the answer is in the question itself, that we only need to give so much as is necessary. And I think 70 to 80% of the women will not need more than 3 to 5 units of syntocinon soon after delivery. So what I usually do is draw up 5 units diluted into 5 ml and give very slowly soon after delivery, and I wait. And if they don't have any added risk factors like induced labor, all those risk factors that we talk about for PPH. So if everything is okay with the 5 units, most of the times they don't ask for anything. However, there are some people who ask for 20 units going on in the drip for the duration of surgery, and that continues for 2 hours because it goes on at 50 ml per hour. So
Yes.
that usually does not cause harm, because syntocinon, if it's continuously going, if it is not contracting very well, it does help. But
Okay.
I'd like to give it very slowly as an infusion, not as a bolus.
Okay. And your experience with carbitocin?
I haven't actually used carbitocin. I'm told that it is available. I think anyone else was asked for carbitocin. I think the advantage of carbitocin is it's not dependent on the cold chain. So that is why the WHO had suggested carbitocin, but we have been using syntocinon and carbaprost as a second line, actually.
We had one of our obstetricians ask for carbitocin. So I made it available in our hospital and I've used it once.
Okay.
The purported advantage, they say, is doesn't cause hypotension like Pitocin does. But the problem, they also say it's like your last drug. So once you've given carbitocin, then you cannot give Pitocin. So I'm just very new to this. So that's why I thought your experience would,
I'd be ignorant about that as well. The WHO certainly has suggested carbitocin for hot, warm countries because we don't have to depend on the cold chain. I think that's why it's going to be available. I think recently from March, I think it started becoming available, but I haven't actually used it. Anyone else with experience could enlighten on it.
Okay. Could I ask one more question? I think I'm hogging
Yes, ma'am.
the stage, but what would you? There are some obstetric anesthetists who use one gelofusine or a Voluven after that first crystalloid has gone, that 500 ml. Would you recommend that? Any? I'm always worried there'll be some anaphylaxis because I'm giving it a bit unnecessarily.
See, I think colloids per se are used only if there is excessive loss. I think crystalloids are the mainstay of treatment as long as normal ASA1 LSCS is concerned. Gelofusine, I think we've gone away because there's a lot of anaphylactic reports from gelofusine. Voluven would be my choice. If at all, I have to use it. But The whole idea is to have a preloading with crystalloid, then colloiding along, and then use vasopressors to maintain the mean arterial pressure to combat with the hypotension caused by spinal anesthesia. I think if we can do that, unless there is excessive blood loss, we don't have to give colloids at all. I think that is my opinion. That is my perception. I haven't used colloids unless there's greater than 1.5 liters loss. Then I begin to use colloids at that point while I'm waiting for blood or blood products.
Okay.
But I usually use volulite. I usually use volulite.
Okay.
Volum and starch.
Yeah. What about cabalite and plasmalite?
Yes. Yes. Plasmalite is again a crystalloid. So we would use it instead of RL. I use it particularly in PIH or elderly mothers. I mean, like I would use it in any other regular case. And normal saline, I haven't used for a very long time.
And for a PIH, severe PIH?
Severe PIH, I think fluids should be very carefully titrated, as we all probably are doing. We have gone away from preloading at all for them because the blood pressure is always on the higher side. And even if you give spinal, they don't actually drop the blood pressure because of the vasoconstrictive status. We would probably have to titrate the antihypertensives that they are going on with. Fluids wise, I would still go on with plasmalite or for the PIH mothers also. Colloids, I would not, because they have a high risk of going into capillary leak syndrome. So I would be very wary about using colloids in these mothers. Definitely not the first choice.
What will be the vasopressor? Your choice. What first you drug will?
In PI, in normal mothers, ma?
Yeah, in normal mothers.
Normal mothers, I regularly use Frenin. Phenylephrine is my first choice. As long as the mother maintains a heart rate and I'm not going to run her into a risk of bradycardia, Frenin is my first choice. I use it in a dilution where I put 1 ampule into 100 ml. So that's 0.1, and have used it in that dilution in half cc. I only use 50 mics at any one point of time. Watch for the response, give fluid bolus, and then only go for the next dose. If at all I have a sick mother who's now requiring more and more boluses, then I would be using noradrenaline. Somebody said phenylephrine is not readily available.
Mefentremine is routinely available everywhere here. So what about that?
I have used metaraminol in the past. For now, I think we only use Frenin. Metaraminol, I have used in the past. I think it's something like 5-6 years ago. As long as you're maintaining the blood pressure, we don't have any reports of using studies using metaraminol in obstetric patients to say whether it causes any particular problem or acidosis. Like ephedrine, I think we used it for many decades, and then suddenly they started saying that it causes fetal acidosis because of the induced tachycardia, and henceforth we started shunning away from ephedrine. However, if you dilute ephedrine very well and use it in combination with Frenin, it can still be very useful. But there is this large number of studies that have been done to say that ephedrine can cause fetal acidosis, that the obstetricians don't like us to use it. But with metaraminol, we don't have any studies to talk about it. We know that it causes vasoconstriction, and that's the way it's going to work, and it's going to improve the blood pressure. Then I suppose in adequate dilution, it should be good. But I always worry about metaraminol is bradycardia. I don't know if you are using it regularly, Kala, you can comment on it.
No, there is no bradycardia as such.
You don't get
okay. No, not much. But it buys us time, rather, to load or get in the blood, or to arrange ourselves. It gets us time to deal with the situation. So mefentrine in low doses, it doesn't cause much harm and keeps the BP good.
Okay.
Yeah, there is one more question from Dr. Bingarde on the YouTube. What is the best non-depolarizing muscle relaxant for GA in eclamptic patients?
Eclamptic patients, see, if it is an emergency scenario and you're worried about airway, my first choice would be succinylcholine, or if you have access to other drugs. But when it comes to non-depolarizing, I always use atracurium. Because I think personally you should be using what you are familiar with and regularly use in your population of patients. If you are using becuronium, well and good, but I use atracurium and I would prefer to use that.
Yeah, even I don't use it.
Next question is from Dr. Sanjay Tabade. Which drug should be used to attenuate the rise or fall in blood pressure in eclamptic patient during general anesthesia?
Sorry, could you repeat that, ma'am? Which drug?
Which drug we should use to attenuate the rise or fall in blood pressure in eclamptic patient during general anesthesia?
Yeah, I think there is plenty of studies about how to obtund the rise in blood pressure. So one, we have to continue with the IV antihypertensives that we are giving for that patient, which is already going in. That's very, very important. Please do not stop that. Second line is you would be giving a cardiac type of anesthesia, good dose of fentanyl, and Dexmed has been suggested in many patients because it works on the heart rate and it is a vasodilator, and alpha blockers can be given in these patients. So Dexmed, there are plenty of studies to suggest. I don't use lignocaine. I prefer to use Dexmed if necessary during induction. Yeah, exactly. And adequate dose of induction agent.
Yeah, exactly. I wanted to ask about Dexmed only, because whether it can be used for pregnant patients.
Yeah. Yes, ma'am. There is plenty of studies, and in fact, the eclampsia protocol suggests that we should be using Dexmed if necessary. Yeah. And if you're comfortable using it, then you will know how to titrate the dose.
Yes. Thank you, madam.
It doesn't have any effect on fetus?
No, ma'am.
There is one more question. Is echo, 2D echo mandatory if possible for all pregnant patients, just as we do thyroid studies?
I think that would be in an ideal world. But the thing is, we must remember echo is a static study, and what is done at booking is not valid while she's on table or as an emergency. Yeah. So there have been reports where actually there was a case on newspaper where the lady had a cardiomyopathy and actually arrested, and they could not revive her. And this lady had an echo a month before and it was normal. So the family said it was not a cardiac problem, but then she did have cardiomyopathy. So then it becomes tricky to defend. But then the point is to see if you can have an echo in an if she is sick on that particular day, if we can get a screening echo on that day, I think that would be the best for us to protect ourselves and to guide your treatment as well. In Tamil Nadu, actually, the government is trying to do echo for most of the pregnant women, at least in the high risk category. In corporate setup, we get echo done. Because 90% of them are PIH. Even if they are not PIH during the 9 month, on the day they come to the they become. So it's always wise to know what is happening inside.
Yeah. So the gynecologist's wife who are anesthetists, they can go ahead with echo and keep it ready.
Definitely. Yeah.
We have to repeat the echo on the day of the LSS also.
Ma'am, if there is any change in scenario, for example, she is suddenly gained weight, 2 days of edema, all that back edema, fullness in the neck, sudden breathlessness, and you feel the chest is also not great, then I think a screening echo would be wise.
Yeah. Okay. One more question is
see, the point patients in whom we did screening echo, I can quote, is the PIH with COVID. Because they both problems together, they used to have capillary leak, and we had to titrate the dose of spinal accordingly. We didn't want to give GA, so we had to get that screening echo before we wheeled them into the OT.
One more question is treatment of amniotic fluid embolism apart from ABCD, and and same related question is that any role of AOK, that is atropine plus ondansetron plus ketorolac in amniotic fluid embolism. This was presented some few weeks from European journal.
As a treatment?
Yeah. Or as a preventive role, I don't know.
I'm not aware of that. Sorry, I would probably have to go back and read about that. I'm not aware of that paper. I could look into it.
And any other treatment for amniotic fluid embolism apart from ABCD?
See, theoretically, as I said, it's postulated that it is an anaphylactoid type of syndrome. So you're expecting something like a massive capillary leak syndrome. So we have to only manage like an anaphylactoid. You could add steroids. We could do ABCDE, get vasopressors in, and prevent DIC, because it's well proven that if they go into DIC, they will definitely not recover. So how to prevent DIC is the only thing. So they have the usual similar to PPH protocol. We have to go with RBC, with FFP, with platelets, try and get fibrinogen as early. If you can get a fibrinogen level at that 0.0 at the time of collapse, if it is low, then you know that, or at least if it is anything less than 4, then definitely giving fibrinogen is the only way forward. This is what the OAA Welsh group and many other studies have shown, because they have tried to do postmortem studies and, you know, dissected through every step that was done for those particular patients. Like abruption, patients with abruption who went on to have amniotic fluid embolism, patients with abruption who went on to have obstetric hemorrhage. They were the cases that they had actually done the study on. I'm not aware of this ondansetron ketorolac. I will read up on that.
Yeah.
There is
Somebody
also
had
one
written
question
about cell salvage. Actually, there are two things that we used to use very frequently when I was a trainee back in the UK. One was cell salvage, and I think it is still used. And the other is factor 7A in refractory obstetric hemorrhage. But because of the cost and the availability constraints, and actually the number of trials have shown that by the time you've used a factor 7A, you know, you've gone beyond a point. It's about how early you give the blood products and prevent DIC. Once you've reached a point of giving factor 7A, they've said that it's probably not worthwhile trying to get it in every unit. I mean, trying to work out the cost effectiveness. But with regards to cell salvage, if you're in a unit that actually has cell salvage, I think a lot of teaching hospitals do, then it's worth it. But it's very difficult to actually try and have it in every small hospital, because you need to prove the safety of it. And with although the risk of perfusing something that's come out, you know, the risk of amniotic fluid embolism, we need to be extremely careful with the cell salvage method. So it, with the guideline perspective, it's been taken out. But if you're used to using it, then it's well and good.
And there's one more question about cardiomyopathy. How do you detect it pre-op or post-op? And how do you explain the relatives about cardiomyopathy?
Can be, I think cardiomyopathy would be, say, the diagnosis is made if the patient has had a cardiac event with a sudden fall in blood pressure. You may have arrhythmias or ECG changes, and you know, irretractable blood pressure. You will need a high dose of inotropes. But the confirmative diagnosis is with the echo. So you need to have an on-table echo. Cardiologist must have come. You have a documented evidence before you can actually explain it to the family. Without that, we won't be able to tell confirmatively, because it could be due to any other reason. It could be vasodilatory shock. It could be septic shock. Patient is in shock is all we know, cardiogenic shock. But what sort of shock has to be confirmed by the echo.
Yeah, most of the times we detect it post-operatively.
Post-op.
And the BP doesn't come up, and then that's when. So, and you have already given spinal.
Yeah.
See, that is why if at all a lady is acutely breathless, or you put a and you think she's looking not so good, then you should probably try and get an. For example, a lot of these cardiac diseases are first time diagnosed when they come for delivery. So yes, many times it's done post-operatively or on table.
Okay, and any specific test for diagnosing amniotic fluid embolism? How will you specific lab test anything for amniotic fluid embolism?
Amniotic fluid embolism, they have only suggested that we should do the complement C3 and C4 because it is suggested that it might be an anaphylactoid phenomenon, and therefore C3 and C4. Because previously they tried to look at the postmortem reports and take out fluids from the lung and check for amniotic fluid, but all of that phenomenon is gone now. So it is all about anaphylactoid phenomenon and checking for C3 and C4 levels.
Any more questions?
Any adverse effect on the fetus while doing defibrillation?
No, ma'am. I think we should not worry about the baby when we are actually trying to defibrillate the mother. That is what the guidelines also, and I think that's what we all have to go ahead and do, because only if the mother is alive, the baby is going to be well. And they have even suggested that we should previously, I think they used to say, have the fetal monitors on, take it away. All that electrical interference does not matter. You can leave the monitors on or take it away. But what matters is defibrillation.
Yeah. And we should continue the resuscitation during PCMS.
Yes.
Yeah.
Yes. Continuously. The CPCR, cardiopulmonary resuscitation, must continuously continue. They suggest that secure the airway. Don't bother about the cricoid. Continue with cardiac compressions. Every 2 minutes, you can change the person who is doing so they don't get tired. It should have a good effective cardiac compression mid-sternum. 4th minute, you deliver the baby, or maximum 5 minutes. I think theoretically or practically, I think it can take longer than that for most setups. But as soon as possible, I think we should make a decision and just deliver the baby. Ideally, would be less than 5 minutes, but you try and make it not too long. That's what it's suggested, because often when the baby is delivered, hopefully the mother will return to circulation.
Kala, any more questions?
No, there was one ideal best induction agent for eclamptic with low albumin.
I think with the low albumin, I think what he's worried about is whether it's going to be acting or not. But personally, I use, if the patient is actually severe PIH and already on a lot of drugs, my drug of choice in pregnant women, if they are cardiac-wise stable, is thiopentone. If not, I use, propofol in titrated doses.
And
anything that you would suggest, Kala? I mean, does it really matter? Because at that point,
propofol is not that easily available. Thiopentone is not that easily available. We get propofol very easily.
So you use that for all?
Yeah, almost all, or rather etomidate is available.
Okay.
Pentothal is not that easily available everywhere. We have to, as a freelancer, we have to carry pentothal.
Oh, see, but propofol is what we use every day, so we should be able to titrate it accordingly. It does not matter about the low albumin, because all we are worried is the first 1 minute, and after that, the tube is going to be in within 30 seconds.
What about inhalational choice while induction?
Sevoflurane. Is that well available? That should be.
Yeah, sevoflurane is easily available. We have ISO and Sevo everywhere.
Yeah. The one more question is from any benefit of intrauterine injection of oxytocin or carboprost in non-contracting uterus? Intrauterine injections.
Intrauterine injections. See, I think all of that has been there as part of the protocol long ago, but when we can actually give it IV syntocinon and carboprost, we give IM. This is more, definitive, because I'm also worried that there could be some blood vessel in the uterus. So I don't want them to inject anything into the uterus. So I'd rather give it IM so I can directly manage at the head end what is happening. So in our hospital, none of them want to do that. If anything, they actually leave misoprostol or Zytotec at the end of the surgery if they want 800 milligram or 1200 milligram at the end. So that actually acts locally and that does not get absorbed directly into the vessel. So I'm happy for them to do that.
So, any other questions?
Defib shock is with the same energy. Yes,
Yeah.
same as you would do if it is any same adult protocol, or VT, whatever you would use, or VF.
Yeah, so the key message is that in all maternity hospitals, they should keep intralipids, defibrillators, and all antiarrhythmic drugs like calcium, like amiodarone and adrenaline calcium carbonate. They should make it available, and we should apply ECG leads to all patients, and there should be CRICO kit available. Yeah. Any other suggestions for small nursing homes?
See, what I always worry is, I think we should not take cesarean as a light case at all.
Yeah.
Even if it is an ASA1. I think this lady has come to us for delivery, which is unnatural. It's artificial method of delivery and we have to send her home carefully. So all the responsibility is on us. And because we are the ones who are rendering her paralytic with the drugs and everything, I think those 2 hours we have to be extremely careful and we have to help her through in the recovery period as well. With my experience in obstetrics in the last 10 years, particularly in India, there's so many dramatic things have happened that I would say that I feel like pregnancy is not physiological anymore. We have to be extremely careful. So definitely all the monitoring that any other appendix patient deserves, this woman deserves more. She has one more life inside her. Any other drug treatment that any other cancer patient or a dying elderly patient deserves, this lady deserves more. So we need to make sure that the environment is more safe for her. And we need to be as a team more geared up to deal with the complications, because I think the generation has a lot of hormonal imbalance. So uterine contraction doesn't happen normally. Their thyroid is all over the place and they are at a risk of cardiovascular diseases. So I think we have to be more geared up. I think the future generation of anesthetists have to be more geared up.
Yeah. Better we have simulatory courses, sort of. The anesthetist can conduct a simulatory checklist preemptively when they are free, rather, and the hospitals can ask their routine anesthetists to do short sort of simulation courses for their staff, and that will be better. Yeah.
See, we do that once. I think the nurses are mandatory to have some points, like how we have CPD points. They also need to have some points to put on their council registration every so often. So we do this once a month, one scenario where it's like you supply some coffee biscuit, ask them all to come in an area, and we run scenarios with pillows and defib trolley and how to call for help. You identify a lot of issues, even how to call the housekeeping to get the blood slip form. Where is the blood form kept? What is the number for the particular lab? Who is the cardiologist assigned for the unit? All of those doubts will be cleared when they actually do these drills.
Yeah.
And it's very important and it's very helpful. I think it's well proven that this is the only way forward.
Yeah, that's where the local ISA branch comes into play. The nursing, what you're talking is about the corporate. So if I want to bring down corporate to the nursing home level or smaller setups, so I think the small nursing homes can have such drill done by the ISA team.
Okay.
Maybe. Yeah. So that should be helpful even in the night time when the staff is also tired. We don't know where things are kept. We are also tired. So this drills come into a lot of help then.
See, and it's only one set of you have one doctor, one surgeon, one technician, and one person to go out to get the blood. Those 4 people cannot do all the jobs expected out of them. So you need to have a backup team also. I think that's something that you can think of in group practice, or if you're an anesthetist practicing alone, you have a friend, phone a friend whom you can call for help in times of disaster, because you will need such help, certainly.
Yeah. Okay. One more question. Yeah, we have done with the questions. Madam,
Yeah.
should we conclude?
Yeah, we should conclude now.
Okay. On behalf of ISA Kalyan, many thanks, Vennilla. This was a very excellent talk. I mean, you covered all the points, practical aspects, and definitely it will be a go-to reference lecture for us. Repeatedly, we might have to come to the YouTube and listen to you. It was fantastic, and on behalf of the entire ISA branch, I give you a heartfelt thank you. Thanks a lot, and I thank all the participants for attending this CME. Thank you, and happy Navratri.
Thank you. Thank you all so much. And thank you, Kala, for having me. Thank you, Dr. Sneta.
You came on to help us in a short notice. I should thank you. Actually, she was supposed to talk on 26th, and we had a speaker falling ill. Of the 7th October speaker, Dr. Pandya was not well. So he requested me to ask Dr. Vennilla. So thank you so much, Vennilla. Yeah.
It's a pleasure. Thank you so much. And it's nice to see you all after a long time.
Yeah,
I hope this helps. And there's always going to be something more to learn and from every bit that we see.
Definitely. And our mothers are very special. So
yes.
we need to have this revision again and again.
Yeah.
Thank you so much. Yeah.
Thank you. Thank you so much. Thank you.
We are concluding the meeting.
Yes.